How to measure with the app. The first thing is to load one image from your photo library or capture a photo from X-rays photos of a patient. Next you fill in the empty boxes according the patient's height in cm and weight in kg, and at last the calibration unit box in mm. After finishing the calibration procedure, with the calibration procedure you try to locate the center of template, a known dimension in mm, object in X-ray, for example a coin, by moving the transparent circular yellow template over the object, coin, trying to fit to a best fit circle to the contour of the coin circumference. Once you have found the best fit by clicking the point button, the center of the coin is marked C1. Next a dynamic circle appears with a C1 center point marked over the screen. The radius of the circle is changed dynamically, and by moving the attached finger you try to find the best fit circle to the contour of the coin. Once you found the best fit you press the point button and the subject, whole coin, is marked by the circle R2. Point appears. If the coin for example is 10 mm you enter the number 10 in the box. Next by clicking the button point you mark 2 points, point S3, left, and point S4, right, over the lateral edge of the superior end plate of the S1 vertebra, sacral end plate. The yellow horizontal line S3 S4 is drawn. Next by aiming the center of upper middle distance of pubic symphysis with the transparent circular template and clicking the button point, the point S5 is marked. An erected vertical reference line from S5 is drawn. Right side. The transparent circular template appears and you aim to locate the center first of the right femoral head by moving the template over the femoral head, trying to fit to a best fit circle to the contour of femoral head circumference. By clicking the point button the center of the left femoral head is marked C6 point, and the corresponding radius of the femoral head by clicking the point button, R7 point, appears. Aiming with the transparent circular template to the lateral acetabular edge you mark the lateral acetabular edge. By pressing the point button, E8 point. Finally you aim with the transparent circular template the deepest point of the roof, the acetabulum or the triradiate cartilage if still open, usually at the halfway of the acetabular width, and by clicking the button point the A9 point is marked. A semicircle is printed. By the same manner you mark the V10 point, which is the lowest and most lateral point on the acetabular teardrop, and subsequently the point where the lower contour of the head intersects the postero-inferior acetabular margin. Point D11, is marked. Finally the site of insertion of the hip abductors on the greater trochanter, point T12, is also marked. Left side. Without to recalibrate you start the same procedure from the left side by marking the center of the left femoral head C13, R14, and as mentioned above with the same order you mark the rest of the points at the left side as follows. E15 lateral acetabular margin of acetabulum, A16 deepest point of the roof the acetabulum or the triradiate cartilage, V17 acetabular teardrop, D18 intersection of femoral head at the postero-inferior acetabular margin, T19 insertion of the hip abductors on the greater trochanter. The distribution also of compressive stresses over the acetabulum, which is usually associated radiographic sclerosis over the acetabular margin, are printed in real time over the screen and thus can be easily and objectively evaluated. Besides that, the app provides data and export for diagrams of load, R, pressure, P, which each can be plotted as a curve allowing easy comparison with normal data and thus help decide the orthopedic surgeon which procedure is objectively indicated. The data are printed over to screen so each case can easily assessed. Save the planned images. For later review or consultation, data are exported as TXT file, ready to print or to input as cells to numbers or Excel ready for chart printing and further research. Based on Tonnis experience with the biomechanical analysis of 460 dysplastic hips in adults, the following simplified general rules for patient selection are: 1. If the load on the hip is increased but the pressure is normal, corrective surgery is unnecessary. 2. If the load is normal but the pressure is increased, an indication exists for pelvic osteotomy. 3. If the load and pressure are increased to an equal degree, such that the pressure and load increases correspond, the pressure can be reduced to normal by normalizing the load. In this case an intertrochanteric varus osteotomy is sufficient. 4. If the load and pressure are increased, and the percentage pressure increase is greater than the percentage increase in load, a pelvic osteotomy should be performed in conjunction with a proximal femoral osteotomy. 5. Valgus osteotomy is considered necessary to obtain a congruent joint. It must be declared whether or not the resulting load increase can be compensated for by increasing the weight-bearing area of the joint so that the pressure per unit area is diminished.